Any questions from anything we covered yesterday? That sounds right. Yesterday, yeah, we talked about muscular function, right? I think that's what we talked about. It's all a blur at this point, which I'm sure it is for you too, but we're going to continue talking more. I'm sorry. Yeah, right now we're on the CNS lecture. Oh, I'm sorry. Yeah, yesterday was like just like actual like functional like neurotransmitters, and yeah, muscle stuff was on Tuesday. Absolutely. Thank you for correcting me. All right, so we're going to go and talk more specifically about the central nervous system in a little bit more detail. I'm going to try not to have a lot of overlap of stuff we've already covered, but some of it will kind of pop back up. And so, again, repetition, as you'll learn, is a key thing to transitioning things from short-term to more long-term memory, as we'll learn a little bit later. So that's why I just repeat myself over and over again. It's all for your benefit, and I'll have you know. Not because I forget what examples I've already used. But so we'll look at things like cortex functions. We'll look at the limbic system, and especially the hypothalamus, and how that kind of regulates a lot of kind of subconscious activities, like our endocrine system and some other things like that. And then we'll look a little bit about brain activities or lack of activity, as you might see in some of your patients. Certainly lack of teachers, in some cases. So, review want to review the cortical brain function, discuss the role in the limbic system, mainly in behavior, and then also in endocrine functions, and then we'll again talk about things like sleep, wakefulness, and then also about seizures, right? So again, not getting super in depth on the pathophys, but at least kind of talking about something that it could be a relatively common occurrence for some of your patients. So starting off with the cerebral cortex. So just briefly kind of looking at the anatomy of the cortex, I'm not going to have you memorize specifically like, layer 1 is the granular layer. Like, that's not super important. Like, at least get the concepts down and kind of what communication's happening here, though. So for instance, with this granular layer, you kind of notice here, and the orientation of this picture is kind of goofy. I think this is kind of from 3 different areas of the cortex, but the book was not super good in kind of dictating which one was which. But anywho, you kind of get the point that in the first layer, we're going to have this kind of granular or stellate layer. We're getting these kind of short axons. These are just kind of interneurons. And this is kind of the top level of the cortex, essentially, kind of the most superficial, essentially. And you're going to see that they are good for kind of short distance communication. These aren't really spreading out to anywhere beyond just the cortex itself, but it's good for communicating information from, say, one area to the other. So for instance, when we were talking about muscle control, we were talking about how a lot of the somatosensory cortex information gets transmitted over to the primary motor cortex, and a lot of that happens through some of this granular layer, essentially. And you'll find that a lot of these are going to be excited by neurotransmitters like glutamate, which we talked about yesterday. And then also they'll have a lot of inhibitory neurotransmission that happens here, and that's going to be through GABA, right? Remember, GABA is a major inhibitory. It's kind of the brakes on the system. Glutamate's going to be the gas on the system, essentially. Then you'll have the fusiform layer. You're going to have this pyramidal layer, and this is where you see a lot of output fibers, essentially. So this is where, especially the pyramidal layer, these are a lot longer neurons. You can kind of see here how these are starting to get a little bit longer, and you're going to see that these are going to start to transmit all the way out through things like the spinal cord, right? So this is kind of where your cortical spinal tract is kind of starting up here. And you'll also see some subcortical association that will kind of go from one brain area to the other, right? And then as you get down into something like the internal granular layer, this is where you're going to have a lot of sensory signals. So a lot of the afferent signals that are coming into the brain, so things like sensory, like muscle spindle information coming from the dorsal horn of the spinal cord gets kind of outputted here. And so this is where a lot of the input comes from, and then the output will come from the pyramidal tract. And then this large pyramidal tract here, a lot of output fibers. This is mainly you're going to see to the brainstem cord as well, and then also many to the thalamus. So these are kind of the main things, the main outputs here, as well as going to the spinal cord. I guess I should clarify that the first kind of pyramidal layer is better for just major areas of the brain to brain, versus 5 and 6. This is more the main ones that are going to be going through the spinal cord. So apologize for that. So anyway, so why is that important? It's important to also realize the relationship between the cortex and the thalamus. And so what you actually find is if you were to destroy, say, a portion of the cerebral cortex, you're going to find that the person will have deficits. But if you were to, say, take out part of the cortex and the thalamus, that ruins a whole lot more problems, or makes a whole lot more problems for the patient. Because mainly every bit of communication happens with the cortex. Eventually, it's going to communicate with the thalamus as well. So there's a lot of two-way communication that happens there. There's a lot of, so it's a very important kind of track to keep in mind. And so we'll call this the thalamocortical tract. Again, it's two-way communication. You kind of see, and again, don't memorize this section necessarily here, but you can see where different portions of the thalamus kind of line up with how it communicates to the cortex. So you can kind of do kind of a one-to-one kind of association between the thalamus here up to the cortex, and you kind of see how those are going to communicate. But again, almost all the sensory information coming to the cortex ends up coming through the thalamus first. So again, all of those kind of input signals as far as like sensory information goes is going to travel through the thalamus first, and it's going to kind of radiate out into different parts of the cortex. And we'll talk about those different areas and how we can get certain features like, things like intelligence or things like word association and whatnot will come from these different areas based on that information coming from the thalamus. Right, so you can see here how it's kind of been broken down into different skills and things like that. So obviously, like back here in the occipital lobe, this is where you get a lot of vision input coming. Again, it seems kind of odd that you think these nerves want to take the kind of the shortest course and just go to the front of the brain, but it doesn't. It goes back to the occipital. But we talked about that back in the vision section. Here you're going to notice there's going to be a lot of things like hand skills. Speech is also going to be really, really important here back in the parietal into the temporal lobe. And then this is where we have our somatosensory cortex, voluntary motor cortex. We talked about that earlier this week. And then obviously things like, elaboration of thought. A lot of that comes from the prefrontal cortex. We'll talk all about these in more in detail. And so what they were able to kind of find, and how do you think they determine what these different areas do? Yeah, so a lot of times they'll cut them, and then they'll see kind of what differences happen. So like if we cut the spinal cord on, not on a person obviously, but say we cut the spinal cord on this rat or this monkey, and then what happened, right? That's one way you could do it. The other thing they did a lot of times is they were taking electrical stimulation. They would stimulate different areas and see what happens. So if I were to stimulate, say, certain parts of the somatosensory cortex, you may have all of a sudden a sensation of, oh, I smell chocolate all of a sudden, or if they hit part of the voluntary motor cortex, all of a sudden, like your arm juts out or something like that. So that's where they're kind of figuring out what a lot of these kind of association areas are, and so you can kind of get a little bit less granular, but and kind of like lump a lot of these things into different association areas. And so this is really important, and we're going to talk a lot about this today, and how for things like, if I want to read words off of the screen and then be able to convert that into language, right? Because again, if you think about, like, when you read a book, do you remember what the page looked like and all the words looked like on the page, right? No, you usually convert that into some sort of like information that you can store as like the message that was conveyed. So I don't remember what page 300 of Harry Potter looks like, but I remember what was going on. I remember he was in the Quidditch match or something like that. I'm sure some Harry Potter nut could probably correct me, like, actually this is what was going on. But anyway, point being is that you convert all of this into language, and convert it into these kind of conveyances of thought, and that's really important. So we're going to see some places where that actually gets kind of screwed up, and these association areas are going to be very important for that. So again, very specifically, you can see what the different areas are going to be used for, but we'll see how these different areas kind of get associated with one another and how they can kind of communicate between area to area. So again, looking at things like the supplementary and premotor areas, these are really going to be important for functioning with that primary motor cortex, and you also see that they associate with the basal ganglia. So remember, that is very useful for us with doing those kind of more complicated movement patterns, right? So if I need to, shoot a basketball, if I need to hammer a nail, something like that, the basal ganglia, the voluntary motor cortex, those are all going to be really important there. And so also, we can do things like, secondary sensory areas. They start to do things like analyze meanings of areas. So, you think about the primary motor cortex, but that's just basic movements. But by incorporating the secondary areas, that's where we kind of get more complicated. Same thing for the sensory areas. The primary sensory cortex, you'll get those sensations, but then you can start to kind of incorporate more information about that. So for instance, if you're looking at the secondary sensory areas, you can look to see, like, well, I'm holding something in my hand, I can start to interpret things like the color and the texture of it. Or if you are looking at something, the light and the color will kind of be able to interpret that. Even sounds, so instead of just hearing sounds, you can start to say, okay, well, this is a melody, this is a chord, different things like that. So the secondary areas are really, really important for kind of getting more complicated than just what the primary areas do. And so these association areas, they end up receiving and analyzing the signals from multiple regions, and they can eventually feed out into other areas so that we can get, actual actionable things from that, right? So for instance, if I were to read words on the page, I can convert that into a language, and then I can convert that into saying something to you guys, right? So we'll look at that process there in a few minutes. Am I making any sense, or my cough medicine starting to hit me funny? I'm just kidding. I didn't take any cough medicine. Just a gram of Tylenol. Okay, so the first association area that we're going to see here is this parieto-occipito-temporal association area. So it's kind of a mouthful, but it's very, very important. It'll do several things for us. You can kind of see it back in this area here. So you see how it involves the parietal area and also the temporal area. So what do you notice kind of is associated with this area? So what's happening back here? Vision. Yep. So vision is really important because it's, again, very close association. And what's kind of happening here? Yeah, there's a lot of speech stuff. This is where you have also just other kind of sensory information. It's all kind of being fed into this association area. So this is really important because this is going to help us to do several things. One, it can help us with kind of analysis of spatial coordinates of the body. So if I'm trying to figure out, like, where exactly am I at in time and space at a particular junction, I can make decisions about that, and that information can be, further fed out to other areas to say, like, okay, if I, something is coming at my face, I can say, okay, my body's too close to that thing, I should move out of the way, or just get hit by it in a lot of cases. But so that's one feature here, this association area. Another thing would be Wernicke's area. You ever heard of like Wernicke's encephalopathy or anything like that? So basically, he's a famous neurologist, and so he got to name his own area of the brain. Essentially, we can all strive to be so important one day. But this is really important for language comprehension. And so when you think about like intellect, and you think about intelligence in a person, what part of the brain do you normally associate with that? You think about the frontal lobe, you think about the frontal cortex, but actually, and we thought that for years, mainly because if you were like compare us versus monkeys, you saw that we have a much more developed kind of frontal cortex. And what it turns out, that's actually probably not truly the case. We'll see where the frontal cortex is really important for carrying out thoughts for more than a few seconds at a time. But especially when you're looking at like lobotomized patients and whatnot. But this Wernicke's area is super, super important because it is so integral for language comprehension, and because for intellect to occur, I need to be able to look at words on a page or hear words being said to me and convert that into language, and by using that language, I'm able to convey meaning from that. And so this is really, really important. If you don't have this, if you destroyed that Wernicke's area, you start to get major dysfunction where people are not able to, they may be able to look at words on a page, but they don't understand what is being read there, or they can hear things and not be able to ascribe any kind of meaning to it. So we'll look at some of those dysfunctions in just a little bit more in detail here. But again, very much language-based, very much a lot of the intelligence of a person ends up coming from here. You also have this angular gyrus area, so it's kind of located right back here, I guess angular, right around this section here. This is really going to be important for that visual association that feeds into the Wernicke's area. So if I'm looking at words on a page, being able to, one, recognize the words and then ascribe meaning to that, and then ascribing meaning to a sentence, right? You can have people have damage to this area, and they can look at words and they can understand that, yeah, that says association, but I won't be able to figure out like what the heck does association mean, because a lot of that's not traveling into Wernicke's area, right? So we'll see some problems with that. And then the area for naming objects, this is also very important because a lot of times, I can see this in my daughter right now, like we're associating things like, okay, this thing that we're saying, like, hey, this is a orange block. Being able to say, okay, well, what does that even mean? How do you start to dissect that? And so we can associate, one, what our visual input is saying, and then also what we're hearing. All that gets fed through that Wernicke's area to try to figure out, okay, this is orange. What does orange mean, compared to this blue block? Okay, what are the differences here? What are the similarities? And by kind of looking at those things, we can make those associations, right? All right, looking at the prefrontal association area, this is very important for kind of working with different motor areas, and helps to plan patterns and sequence of movement. So back in the day when you had patients who had severe psychosis, we didn't really have good drugs to treat them. This is way back in, before we even knew like, washing your hands was probably a good idea when you did surgery, right? They're like, it's weird, all these patients keep dying of infections. I wonder what's going on. They're smoking in the, OR suite. But they were able to do things to try to help these patients out. And so have you guys ever heard of a lobotomy? What is that? Yeah, so essentially, and if you look up pictures of this, if you're freaky about eye stuff, I urge you not to. But basically putting a small blade up through the eye into the brain, and they're able to make a severing of the connection between the frontal cortex back to other parts of the brain. And so you're able to see certainly these patients who were psychotic and having hallucinations and were very aggressive, they certainly got very placid, but you also lost the ability to have a lot of the prefrontal association effects. So doing things like planning out what I'm going to do over the next 10 seconds or longer, right? So being able to incorporate several thoughts at once into my working memory to be like, okay, well, he's telling me about this association area and this association area. How are they working together? You lose a lot of that that ability to kind of put thoughts together in a lot of cases. So that's why we thought intelligence was so much based in the frontal cortex, but now we're starting to realize there's a little bit more to it than that. So again, we'll see that there's strong association here with the parieto-occipitotemporal area. So again, a lot of communication happening between these two areas that help us to, when we convert these things that we're seeing or hearing into thoughts, how can we plan those sequences out to make actionable, do actual functions there. Also is going to signal into the caudate portion of the basal ganglia, and so this helps us to sequence movement as well. So we saw that if you go back to that caudate sequence of movements, or the caudate circuit back from probably two lectures ago, you saw that the caudate circuit had a lot of input coming in from the frontal cortex, and that helps us to sequence out those movements and do those kind of more complex motor patterns. And then, again, very essential for thought process. We talk about our short-term memory as working memories. So when you're kind of, looking at different things like a logic problem, like you're able to take into account multiple facts at one time, put them together in order to make a solution, right? So if you think about, like, ever run into those word problems where they're like, you have 5 people and Joe doesn't want to sit next to Sally and Sally can't be next to this person. Like being able to take those different facts, hold them in your memory for a short period of time to come up with an answer is something that people that don't have this connection can't really do, right? So they kind of have very short attention spans. They have very kind of flight of thought kind of issues there. So that working memory is super, super important, and also just planning out motor and non-motor kind of information there. So we'll talk more about that a little bit later as well. Okay, we also have Broca's area, and so this is important for planning out the motor patterns that we use for expressing words in short phases. And so this one is strongly associated with Wernicke's area. Mine's probably working on overdrive right now because I'm trying to incorporate all this stuff that I've been reading and all these things that I've been watching videos on and incorporate it into actual thoughts, and I can translate that into words. And so you can see this word formation here, and basically the Wernicke's area will communicate over to Broca's area, and then that will communicate out to the motor cortex, and that will allow me to change the words that I want to say into actual laryngeal movements or breathing patterns or movements in my mouth and things like that in order to get the words out. Okay, and so if you have issues with these areas, either of these two areas, you get different types of what we call aphasia. You guys know what aphasia means? It's like you can't talk, right? And so we're going to find there's different problems that come about when you have these different areas become damaged. And what do you think is kind of the most common reason for these areas to become damaged? Stroke's a huge one, right? So stroke's a really big one, especially with other concomitant disease states like hypertension, diabetes, all these things that put you at risk for stroke. This is one of the big ones, right? But certainly cancers, certainly tumors can sometimes destroy some of these areas. Lots of different things can do it. Drugs in some cases, so there's lots of reasons. But we'll find that stroke is going to be one of the major things with this. We also have the limbic association area. We're going to talk about the limbic system a little bit later during this lecture, but this is important for behavior, emotions, and motivation. So you kind of see the beginning part of the limbic association here on the temporal lobe, and then you can see how it kind of communicates down here, kind of on the underside of the brain. And frontal lobe over here. What are these right here? Yeah, it's that olfactory bulb you can see there, right? So, but it's the olfactory bulb. I'm going to go with that. Anyway, it's not important for our class today. But anyway, point being is it also is going to communicate through here. And you notice I have a huge amount of information about, or a huge amount of brain space basically dedicated to facial recognition, right? So being able to detect differences between, all 64 of you guys at any given time, right? Being able to associate that with things like names or your previous histories or any other issues or things like that that come up. And so if you have a problem with this, if you have damage here to this area, the limbic association area, you can have what we call prosopagnosia, and that's basically going to be called face blindness or the inability to recognize faces. So basically everyone kind of looks the same to you. You can't really tell any differences between them. So if I ever don't remember your name, just assume I have damage to this limbic area and I have prosopagnosia. It's not because there's a lot of you guys and I have a really bad memory, okay? Just assume I had that problem. But anyway, so we'll see a lot of issues or a lot of work done with behavior, emotions, and motivation will come from the limbic area. We'll talk about this in detail a little bit later. Okay, so more detail into Wernicke's area. We also call this, there's several names for it, but you can also see it called the general interpretation area because so much sensory information comes in through this area of the brain and it gets incorporated into our intellect essentially, or intelligence. So we call this the general interpretation area. And so you find that it will become dominant in one side of the brain versus the other, right? So in people, what is the most common side of the brain to become more dominant? The left, right? even though most people are right-handed, but usually you end up finding that obviously due to the neural connections, obviously it's the flip side of that. So usually the left-handed hemisphere is going to become the more dominant one, and so there's some reasons why they think that is. Obviously, it potentially could be the left side for some right-handed people. Usually it's going to be more kind of motor dominance. We'll talk about that in detail in just a few seconds. But what you can find is that this is really important for higher comprehension levels. That's why usually you hear like left brain people are going to be more kind of like concrete thinkers, more kind of logical, things like that, versus like right-sided people are more like creative, or they're into music, whatnot. But I didn't mean to like say that so flippantly. Like that's super important as well. I do. Okay, who's left-handed? Just okay, so we could probably do the numbers to figure out if that's right or not. But yeah, so all right, so I am certainly a right-brained person to some degree. I'm probably a little bit kind of half and half, I think. But anyway, yes, that is very important. The creative side, the music side, yes. Which is important because the right side, the non-dominant side is also where you have like a lot of interpretation, like intonation and body language and stuff. So you guys' right side, if you're if you're left dominant, you're using that area very, very well. So good job. I was able to turn that into a lesson. Perfect. All right, so if you have damage here, some of the things that can happen would be things like, if you may be able to hear and you may be able to recognize words, but you can't really arrange them into coherent thought. So again, the information is being processed appropriately in different areas, but if the Wernicke's area is damaged, you're not going to really be able to turn that into any kind of coherent thought. You may be able to read, but you can't recognize kind of what that thought is really conveying. So you can see words on a page, but you're not really able to ascribe any sort of meaning to them, which you guys might be experiencing right now to some degree. But if you have damage to that angular gyrus, this is actually preventing a lot of that visual cortex information from getting into Wernicke's area, and so that would be more specifically the inability to kind of recognize meanings being ascribed to words, in which case we call that word blindness, otherwise known as dyslexia, right? So they can see words, they may not really be able to ascribe any meaning or really kind of interpret, what those words mean for them, and so that's kind of one thing you can see. Certainly on the auditory side, you can have word deafness, where you can be saying a lot of things, but you can't ascribe meaning to what they're saying, right? Again, something that probably happens very commonly in this room. But looking at the dominant hemisphere, basically what you see is that the left hemisphere becomes dominant in about 95% of people. So again, this is really more looking at that temporal, occipital, parietal area, association area that tends to be more dominant, probably about 95% of people. The remaining 5% either will have kind of equal dominance of both sides, or they will end up having the right side become dominant, which is rare to occur in a lot of cases. And the reason for that is that when you're looking at like neonates as they're developing, they typically see that the left side tends to get larger a little bit faster. So for instance, they're about 50% larger in the left hemisphere and over 50% in neonates. Like as they're born, you'll just see that development there. It's one of those things where you obviously kind of favor the side that is more developed, and so they start to develop more kind of thought and intelligence and things in that area. So as you use it more, it gets more use, it gets more development, and so that ends up becoming basically the dominant hemisphere for that patient. And so you'll find that the premotor speech area, that Broca's area, tends to be almost dominant in the left area, almost consistently. And then looking at the motor areas, again, that will be dominant and probably in the left hemisphere for about 9/10 of people. So probably about 1 in 10-ish are going to be left-handed versus everyone else being right-handed. And it all goes back to which of those hemispheres became more dominant. Now, of course, there's communication between the left and the right side of the brain. Otherwise, you'd have all kinds of kind of odd abnormalities that occur there. But the corpus callosum is going to be the most important thing to communicate there. So there's really kind of interesting stories or patient vignettes where if you cut the corpus callosum, or if that's been damaged, basically the patient has kind of two conscious halves of the brain, and so things that happen on the left side don't get communicated to the right side. So they can, if whatever side is dominant for that patient for the motor cortex, they could say, for instance, write something down with their right hand, and if they were to transition over to the left side, they would not be able to recognize they even did that, right? So it's kind of cool, some of the things that you can see go wrong for patients. It's not cool for them, obviously, but it's interesting to see what kind of damage done to the brain and what the manifestations are going to be. Okay, So looking at the role of language in our intellectual function, so again, a lot of that sensory experience gets turned into basically language equivalents for both storage and also for further interpretation. So again, you don't remember what the page of the book you just read looked like, but you remember the thoughts that were being conveyed, you remember the story that was happening, you remember the facts that were being conveyed to you. And so because of that, Wernicke's area is going to be the major kind of incorporation area for all of that. We also see that it's closely associated with the hearing areas as well. So when you take the information that I'm spewing at you, you're able to kind of convert that into kind of thoughts and hopefully be able to process that. You may have to listen to it a few times, but you can convert it back into memory eventually and be able to regurgitate it on a test, right? We'll talk about memory a little bit later. So if you look at functions in the non-dominant hemisphere, so for most people it's going to be on the right side, you can see the destruction of the dominant hemisphere, you lose almost all intellectual function. So they really are not able to associate language or any kind of verbal symbolism. They can't read anymore, they can't do math problems, logic problems are very difficult for them. And so instead what we see with the non-dominant is not necessarily that it's not intelligent, it's just working with different types of intelligence. This is going to be more for things like interpretation of music, looking at certain visual patterns or spatial relations, and then looking at things like body language and tone of voice. So that's, basically this kind of offloads those sorts of other types of intelligence onto the other side of the brain. So again, thought was thought to be the locus of higher intelligence for years, and so we were thinking that the thought process is coming from the frontal cortex. This must be the reason why we're intelligent. We thought that for a long time because of patients who received those lobotomies. So one of the things they ran into is that when you cut that connection between the frontal cortex and the rest of the brain, is that one, they became very placid and very tame. So there were some areas of the limbic association area that was cut as well. So that's where you saw some differences in behavior, which is kind of what they were going for, because those patients were usually psychotic beforehand, were very danger to themselves or others. But they also saw that they were not able to process coherent thoughts for very long. They could only follow a thread of information for maybe a few seconds or so, and then they kind of lost it, right? So it's kind of like Dory from Finding Nemo or something, where she could follow something for a few seconds and then lost it, and so they can't really carry out goals, different things like that. So that's why we thought the frontal cortex was so integral to intelligence for a long time. But what we know instead is that the frontal cortex is going to, or the prefrontal area is going to be better for this elaboration of thought, or kind of used as a working memory. So I mentioned kind of hearing several facts, being able to kind of associate them together, and being able to use that information to, say, solve a problem or achieve some sort of goal. So we can use it for things like prognostication. What is that? Kind of predicting the future to some degree, right? So if I drop my coffee on the ground, it's probably going to make a big mess, right? Little things like that. It seems like the prognostication is not something good my daughter does right now. I'm like, well, you threw your thing down on the ground now. It's not there for you to play with anymore. She doesn't get that, right? So she's still working on some of this stuff. But being able to plan, looking at things like, delaying a response to a stimuli until you have kind of more information that's received, and you kind of can able to select the best course of action. So what you saw with some of these patients who were lobotomized, they would be very kind of impulsive. They would kind of act on impulses very quickly. So things like, you'd see some inappropriate sexual behavior because they would see someone they liked and they would start to act on that thought without really saying, like, wait a second, perhaps they don't want me to inappropriately grope them, or something like that. So these are kind of the things that they were not able to really process because they were losing that connection there. You're not able to solve like math, legal, like philosophical issues that can come up there, and you're just controlling activities according to moral laws, right? So for instance, like it's probably bad habit to go and slap your neighbor on the head, right? But that thought came into your mind, you were lobotomized, you might not be able to really make that connection and just slap them anyway, right? So some people probably need to be slapped to wake them up a little bit, but that's fine. I won't tell anyone. So looking at this function of communication within the brain, we can see here that we need to look at the sensory aspects of communication, and if you have any damage here, certainly there can be a problem with actually being able to interpret what you're seeing because that communication is not being traveled over to that Wernicke's area. And then we'll look at the motor aspects of communication as well. Usually what you see is that for something like speaking a heard word, have you ever watched Parks and Recreation? It's like, have you heard with Bird? That's what I think about when I say that. But anyway, so you have that primary auditory area that gets traveled to that Wernicke's area. So I'm able to use that information I've stored there. It's like, oh yeah, I've heard the word prosopagnosia before. I've heard that word. I did the little button on Google where it tells me what the pronunciation is. I don't sound dumb. So I stored that information. I was able to travel that to the Wernicke's area, so I can associate meaning to it, and then that will travel over to Broca's area, which we said is important for kind of generating kind of the motor functions of speech, and then that will travel up to the motor cortex. Very similarly, for things that you've read before, in order to convert that over to words, you can use that primary visual area. Again, travels up through the angular gyrus over to the Wernicke's area, and then eventually to Broca's area, and it follows a similar pathway at that point. So again, if you damage any of these spots in the chain, then you have aphasia that can occur there, right? So for instance, if you were to have damage in, say, Broca's area, you could have coherent thoughts. You could be very intelligent, but you're not able to really communicate those words or turn those thoughts into words. And so that would be what we would call an expressive aphasia. You're not able to really express those words even though you have the thoughts in your head, which sounds very, very frustrating, right? On the other hand, if you were to have, say, damage over here in the Wernicke's area, you can have much more of kind of a receptive aphasia, where basically the information, you're not really able to form coherent thoughts. You're not really able to ascribe any meaning to the words you're saying, but you can talk just fine. So I'll show you some videos here in just a minute of stroke patients who one's had damage to the Broca's area and one who's had damage over to somewhere like the Wernicke's area. And kind of you can look at the differences between them and see how their disease states kind of manifest. Yes? Yeah, essentially, and you'll see in the video in just a few seconds how the guy is just like, he can talk totally fine. It's just like the stuff he's saying is utter nonsense, right? So he's not really able to carry those kind of coherent thoughts. He's not able to turn what he's seeing and what he's hearing into any kind of actionable, intelligent thoughts, right? So I don't know what would be worse in those cases, either being stuck in a spot where you can think but not really talk very well, depending on your motor functions, you may be able to write, but it depends on where the stroke damage actually happened, or just being in a spot where, I just can't have any coherent thoughts whatsoever, which I rarely do anyway, so I guess it wouldn't be a big change from what's going on now. So, anywho. So I mentioned damage to those areas. So damage to the auditory or the visual association areas leads to that inability to either understand heard or read words. And so the auditory and visual receptive aphasia, essentially. So if you just had damage to those areas specifically, so you may have a problem with either word deafness. So again, I cannot ascribe meaning to things I'm hearing, or you could have issues with word blindness, which would be dyslexia, essentially. So did you ever hear about the dyslexic atheist? He didn't believe in dog. Okay, anyway. On the other hand, if you had damage to the Wernicke's area, this is where you cannot really interpret things that you have, any kind of spoken or read words. So you may be able to say, like, yeah, that says areas, it says association areas, but you can't say, like, well, what does that even mean? Like, you're not really able to come up with those sorts of meanings there. And so we can call this a receptive aphasia. And so this can kind of progress, especially if you end up having further damage to things like the angular gyrus and whatnot. That can form this kind of global aphasia, where really they're not able to really have those coherent thoughts. They cannot communicate. It can be very, very debilitating to the patient. And then, of course, that Broca's area damage there, they can decide what to say. They can, have coherent thoughts. They can come up with, like, hey, this is the idea I want to communicate, but they're not able to make the vocal system work appropriately. So that Broca's aphasia or expressive aphasia there. So again, you could also have damage up here in the motor cortex as well. So even though the brain's sending the signals of what to do, you may not be able to carry that out in those cases. So it would be another type of expressive aphasia. I'm hoping this works appropriately. Let's see. What I'd like to do is play it. So this guy has fluent aphasia. So his Broca's area is working totally fine, but this is also what we call Wernicke's aphasia. So I'm hoping the sound will work. Poor comprehension, but speech is pretty effortless.
How are you?
I'm happy. Are you pretty? You look good.
What are you doing today?
We stayed with the water over here at the moment and talked with the people over them over there. They're diving for them at the moment. But they'll save in the moment. He'll have water very soon for him. With luck for him.
So speech is effortless for this guy, but just the thoughts are not there.
Right there.
And what were we just doing with the iPad?
Right at the moment they don't show a darn thing.
The iPad that we were doing. Like here?
I might change for me and change hands for me. It would happen. I would talk with Donna sometimes. We're out with them. Other people are working with them. I'm very happy with them.
So a very cute old man. But you can see speech is totally effortless. Like he's able to, that Broca's area is working very well. It's just the signals it's sending to the Broca's area is not really anything that's super useful for us, right? So on this guy here, he's going to have this non-fluent aphasia where the words are very difficult. He's have a lot of effort to speak, but the thoughts are all there. You can tell that he's still having these intelligent thoughts here. So again, kind of a very frustrating kind of thing I was thinking of to occur, but.
us your name.
Mike Caputo.
And Mike, when was your stroke?
I was 7 years ago.
Okay.
And
what did you used to do?
Worked Autodesk, seven sales and worldwide, and very good. Yeah.
Okay, and who are you looking at over there when you turn your head?
That's my wife.
Okay, and why is she helping you to talk?
She's a speech.
So you have trouble with your speech?
Yeah.
And what's that called?
Aphasia.
All right.
So you got to get the point. So words are very difficult for him to find, but obviously he's still able to think, hey, I worked in sales, I was very good at sales, or I had a stroke, but the words are very difficult to come up with, right? So again, both very kind of sad conditions, either you're not really able to come up with those coherent thoughts, or you're just not really able to express them. Kind of both kind of are terrible. Yes.
Some of the expressive aphasia would be difficult for them to learn sign language.
I don't know. I guess it would depend on their ability to, if there's any damage to the motor cortex, right? So depending on where the stroke lesion was at, so perhaps if it was just the Broca's area, since that's more contained to speech, they might not have a problem. I don't know. It's a good question for like a neurologist who kind of deals with patients a lot more frequently. That would be a very good question. Again, people spend their whole careers doing just this kind of stuff. So they might know a lot more than I would. So yes, ma'am.
So if it wasn't for like external responses, would they know that this is wrong with them?
The guy on the right with the more kind of expressive aphasia, he would probably end up having be more cognizant of it. On the guy on the left, I'm not sure. Probably be much more dependent on just the extent of the damage and kind of what happened. And again, like this is stuff you'll see like when you do like CTs of the patient, or if you're looking at different areas, like you can see the damage is actually being done as the tissue starts dying off and as it starts to kind of develop scar tissue and things like that. So yeah, good question though. Okay. Oops. All right, so moving on from kind of the temporal parietal occipital association area to more looking at thoughts, consciousness, and memory. So again, memories tend to be stored by changing some of the sensitivities. We kind of mentioned this briefly before, but it's based on that synaptic transmission. We're thinking that these thoughts that are occurring are based on certain sequences of these synapses that are firing off. So based on how they're either being inhibited or excited, and how those transmission is occurring through that sequence of neurons, that is what we're saying. Hey, these are memories essentially. And so what we see is that we will form what we call memory traces that occur. And so when you use that circuit once, it's all fine and dandy, but by using it repeated times, that makes it much more permanent. And so we'll look at the different types of memory and see how those changes occur. But normally what you're going to find is that for kind of short-term memory, there's not really like a lot of storage that goes on there. But as you move it into more kind of long-term memory or more intermediate memory, you're going to find that certain circuits become much more kind of preferentially fired, even to the point where you don't need that initial stimulus to have that memory in the following times, and then to a point where you actually there's actual physical changes that occur to the neurons, to things like the synapses, that will make that much more of a permanent connection versus something that's just being kind of more facilitated by the CNS. And we'll look at why that is in a few minutes. Now, most of the memories that you have are negative. You've had a very depressing life up to now. I'm just kidding. Not negative in respect to happy versus sad, but negative versus into the memories, the sensory information you can throw away, right? And so we'll find that we said that about 99% of the information coming in through the sensory organs are going to be useless in a lot of cases, except for all this sensory information. This is all very useful for you guys. But basically, that useless information gets ignored, and you can have those pathways actually being inhibited. So we call that habituation, where they say, hey, we don't really need that sequence to fire again. Let's just go ahead and inhibit it. Okay. On the other hand, those positive memories, the things that we want to remember, things that we want to store for longer use, those become more sensitive, and so we call that being facilitated. And that way, that kind of gets changed over from just being a kind of a short-term thing you remember, say for the next few minutes, over to something you can remember for days to weeks, up to something you remember for potentially a lifetime. Right. So for instance, like, who remembers their, when they grew up, what their home phone number was? Hopefully everyone, right? Who remembers what anyone's phone number is now? Like any of your classmates? You wouldn't know. Like, I barely know what my wife's phone number was for the first like 3 years we dated, right? Because you don't need it, right? So it's information you got at one point, but you never use that stuff again, right? So it never really got facilitated like the same way like your home phone number back was when you actually had to dial into a phone, right? So those are the kind of things that you think about, the use it or you lose it kind of thing, where the more you use that information, it can transition from, you know, that short-term kind of memory to more intermediate to kind of long-term. So two main types of memory that we'll deal with. There's going to be the declarative type of memory, and so this is going to have kind of various details of integrated thought. I should say thought, not though. And basically this is kind of important experiences. These are things where you remember the time, the place, like I remember my wedding, or I remember when my daughter was born. You're ascribing certain meanings to this, and those are the kind of things that you remember. That's declarative memory versus more skill-based memory or motor activities. And so this would be things like playing the guitar or riding a bike or things like that. And so the memory is a little bit different in the different areas where they actually get affected. And so we're going to see the hippocampus is really important for storing a lot of this declarative memory. But you can find that some patients, even if they have some hippocampal damage, they can still develop these kind of motor activities. So you can see that they get stored a little differently. The pathways are obviously different in some respects. And so damage to different parts of the brain may lead you to be able to do one versus the other. So I mentioned short-term memory is going to be typified by kind of memory of 7 to 10 numerals. So think about like a phone number or just a few different facts. I'm sure if I gave you a phone number right now and said, hey, remember this, and you didn't write it down, if I asked you again in 10 minutes, what do you think the likelihood would be that you'd remember it? Not great, right? Unless I kept kind of hammering and kept talking about the number over and over again. Like, so it's one of those things where, again, you don't use it, you end up losing it. That's only while the person's thinking of the fact. So if you get distracted because I'm talking about something else, you're probably going to forget the thing that I was just mentioning, right? Which is why I like to record my videos, so that way I know you guys probably forget most of the stuff I said from already the beginning of the lecture. You can go back and hear it over and over again and try to facilitate those kind of memory circuits. On the other hand, though, the intermediate to long-term memory, this is where this is going to last for several minutes, up to weeks, potentially. And then those memory traces that we were talking about, they're going to get more facilitated. But if you don't continue to use them, you're going to forget it over time, right? So, for instance, you guys probably use a lot of intermediate to long-term memory. If I gave you the same test for Section 1 today, how well do you think you do? Probably not great, right? There's a lot of binge and purge that goes on in professional school. I did the same thing in pharmacy school. I probably couldn't pass any of the tests that I had to take back in, 2010 or something. So because of that, if you don't use that stuff, the memory traces end up getting lost eventually. You know, some of the facts I'd certainly remember because I use them over and over again, or I use them in professional practice, or, you know, it's like one of those things where, I know lots of peds stuff because I do peds stuff all the time, but then you start to lose more of the adult things that happen. So when I, have to go do, run a code for an adult, some of that stuff is like, a lot of this is ingrained, but I don't remember this one particular dose for this thing because I never use that. I never have to use that information. So some of that can come rushing back when you start to activate that circuit again, but other things can get lost over time. So again, this probably classifies most of the stuff you're learning right now. Hopefully some of it will stick. That's the goal, for someone to at least stick to when you get into clinical practice. You can go, oh yeah, I remember something about that, and you can at least find the information pretty easily. Same thing for pharm. You guys are not going to remember every single drug I'll talk about, but you can at least go, that seems familiar. I should probably look that up. That's my main goal for you guys when you get out of my classes. Anywho, so that long-term thought, that memory, this actually occurs when you have real structural changes that occur to some of these memory traces. And so essentially some of the changes you can see, things like changes in the vesicle release at the synapse, so maybe having facilitated release of more of those vesicles dropping every time you have activation of that memory. Increased presynaptic terminals, lots of different things can occur to make that more of a facilitated memory, to make it more of a structural change that makes it so that it's ingrained forever. So you're always going to remember your home phone number from when you grow up. You're probably always going to remember your home address, things like that. That information has been used and stored for a long time. Even though that information may not be super relevant nowadays, you always are going to remember it.
So what about those things that, just to say, it's like, do you have a picture in your head of like how your house looked or something like that, but then years and years later you go back, it's not how you exactly thought it was, how your memory changed?
That's a good question. There's a lot we don't know about memory still, and so we'll there's a lot of kind of cop-outs for some of the stuff where like some of this is just like, these are the theories that we have on a lot of this. Because again, like stuff like Alzheimer's, like we're learning a lot about memory based on the changes that occur in patients with Alzheimer's. That's the main thing where they're going to start to lose a lot of that memory and stuff. And certainly you always will have a imperfect memory of the things that are happening to you. So, you know, that sensory information, you may neglect certain details that your body's finding unimportant, right? So you may neglect to be like, oh yeah, I forgot that there was that corner there that I stubbed my toe on, or that may be the only thing you remember, you know. So different details like that, and could be potentially degraded over time if you don't remember them. But yeah, I don't know. There's probably more stuff we'll learn about this as time goes on. We get better information about how memory is stored and how it works. So it's one of those things where it's like, oh, we don't really know. This is our theories, though. Yeah, every time you remember something, it seems like, you know, you always have a little bit rosier memory of than it actually had occurred. Like, oh yeah, I remember that. I was really prolific and really smart sounding when I did that. And I go back and watch the video and I'm like, oh no, that was bad. So again, you remember those positive memories. You discard a lot of that negative stuff that you forget about, right? So again, looking at the kind of short-term memory, it has to be consolidated before it can come into the long-term memory. So this is another one of those things where it's one of those kind of theories we think where basically when you have kind of a short-term memory, we think there's kind of this reverberating kind of circuit that happens where you're kind of storing in kind of that working memory, especially in the prefrontal cortex. And so basically it takes time for you to kind of consolidate that to make it more of a kind of a more sustained type of intermediate to long-term kind of memory. So this is why, you know, we always recommend that students at the end of the day, you've been sitting here for 8 hours kind of just ingesting all this information, just go back over it real quick, you know, spend 30 minutes kind of going over what you learned, and a lot of that helps to consolidate that information. It helps to store that information more efficiently. Sometimes it takes more than an hour or so for actually to have strong consolidation, so you're kind of perseverating and thinking about this stuff for a long time. But certainly we can find that there are conditions where you can actually wipe out the information that you had just heard. So for instance, you know, we call this retrograde amnesia, where you forget events that occurred up to a certain point. So for instance, if I put, you know, crazy purple knockout gas into the room, knocked all you guys out, you might forget basically the last hour of lecture, right? And so because a lot of that information had not gotten processed and consolidated into more intermediate term memory, you forget all about that. So we do this very frequently for therapeutic purposes in patients who come in with injuries. So say for instance, you fall off your bicycle, you end up having a displaced fracture, you're in a lot of pain, you're freaked out because now all of a sudden you're seeing bones stick out of your shin, you're just like, oh gosh, this is terrible. And then we were like, okay, we're gonna give you some Versed, we're gonna give you some benzodiazepines that help the GABA work better, we're gonna help shut down part of the nervous system, so that way it's very inhibited and they feel very calm and relaxed. And guess what? When they are out of the effects of that drug, we've actually suppressed their ability to remember a lot of that stuff that was going up to that point, and they have this retrograde amnesia. So now all of a sudden they're like, oh yeah, it wasn't that bad when I broke my leg, even though like they might have been totally freaked out the whole time, right? Because we're able to kind of affect that short-term memory before it was more consolidated and become more integrated into a more long-term type memory. So you can do this with, you know, general anesthesia. So patients going into surgery, they probably won't remember. They're kind of amnestic. They won't remember the preceding moments that came up to when they were under surgery. You know, concussions can do this. Certainly seizures. Patients can have retrograde amnesia when that occurs. So basically, that's just that inability to recall things that happened up to a certain point. I'm sure some of you guys have, or at least seen friends who have imbibed ethanol, right? What kind of happens when you have a little too much ethanol? What do you call it when you kind of wake up the next morning? You're like, I did what? The blackout, right? You have a blackout because you wiped out a lot of that retrograde. You have had that retrograde amnesia. You wiped out a lot of that information because you did not get a chance to consolidate and store it into more kind of long-term memory. So you wake up and you're like, oh yeah, you totally crashed your car into that tree, and you made out with this person, and they're like, oh gosh, I don't remember any of that. On the other hand, though, if you were to have maybe partial recollection of some of that, what do they call that? Yeah, then you have like a brownout, right? So you at least have some memory. You're like, I think I remember doing that, and then you're like, oh wait, how did I end up in Tijuana, right? You don't know, right? So, yes.
Sorry, back to the previous thought about
Sure.
Giving the medicine for seizures.
Yeah.
That's not done with the purpose of like clearing that out. That's just done. It's just like an accidental thing.
Yeah. So sometimes you are using the medication that's an unintended side effect. So if I'm like having a patient who's really worried about going to surgery, or if they're about to have like say their fracture reduced, that is something where we like that retrograde amnestic effect, right? So kind of call that a twilight amnesia that occurs because the patient's kind of out of it. They're not remembering what's happening at that point. They're not remembering some of the preceding events, unless it was a particularly long time or strong memory, and then they oftentimes don't remember anything until that drug effect is kind of gone at that point. But for someone who's having a seizure, obviously they've already kind of wiped out some of that themselves, right? Because they are having, we'll look at seizures in a little bit later, but you're basically having kind of this global depolarization of the CNS, and that wipes out a lot of those short-term memories. But the drugs we give for that will also kind of do the same thing, right? So a lot of times patients who wake up from seizures, once they're kind of back at their baseline, they're like, I was at school, like I don't remember getting to school, right? Or things like that. It's kind of more kind of mundane memories that they did not have a chance to store, right? So, but again, rehearsal enhances transference. So again, we really encourage you to try again. Always look at your stuff over and over because that helps to transfer that short-term memory back into more intermediate to long-term. New memories, they end up getting codified during this consolidation. So this is really important in the fact that you can compare it to old memories for similarities and differences. And this helps with recall very significantly to where, like, you guys have a background. You guys have all had some college courses. Unless someone snuck in under the wire or something like that. But basically, like, you can compare. You're like, oh yeah, I took physiology before, and this guy, what he's saying right now is completely wrong. I'm going to discard all this information. Or you're like, oh, they described it this way versus how Dr. Wood does it this way. And then you can kind of make those differences and similarities, and you can recall that information better now. So that's why, experience is super important, and being able to apply that previous experience to new memories helps you to recall it that much better. So I mentioned the hippocampus promotes storage of memories, and damage here makes it so you have a hard time remembering making new long-term memories. Yes, ma'am.
What does codified mean?
Basically, you're categorizing it, you're codifying it into a specific sort of. Think about the storage bins you have in your mind. Like, if you can imagine it as being like a physical place. Like, I don't know if you guys watch that movie Dreamcatcher. It's a Stephen King book, but basically, like, this guy goes into his mind and he can see like all these different bins. So like, oh, here's 80 song lyrics. I'm going to put this new song I heard into that category. And you can compare and contrast things. So it's just an easier way to categorize things. So for instance, like jokes. Like, I make some jokes. I'm known to do so on occasion. I don't remember all of them at any given time, right? So you'd ask me to tell you a joke right now, I'd be like, I don't know. But if I hear an association, if I hear something about can't even think of one now. Like dyslexia. If I hear dyslexia, and I can think about, oh yeah, the atheist, the dog thing. So that association comes because I've been able to codify that memory, and for whatever reason, I have a disproportionate amount of my brain dedicated to remembering that stuff. Not super useful, but it's there, right? Anyway. So when you have damage to something like the hippocampus and you cannot form new memories, we call that anterograde amnesia. Certainly in those cases you still have skill memory that can occur, so you can learn how to do new skills, but you may not be able to remember, say, like the experiences that go along with them, right? So anterograde amnesia would be that inability to make new memories going forward. And certainly sometimes, like when patients are under the effects of drugs or they've had a seizure, they could be in a state where they're not making new memories due to the effects of those things, but usually when they come out of it, the drug is gone or they're back at baseline, then they can start that memory process again. So and we'll talk about the limbic system and talk about reward and punishment centers a little bit later, but the hippocampus is really thought to be associated with this. So you tend to remember good memories, and you tend to remember things that made you feel really good and things that made you feel really bad. In a lot of cases, you don't remember the stuff that was kind of like meh. Like, so, a week from now, you're not going to remember the drive in to school because it was there's no stuff associated with it. You might remember this class because it was, activating the punishment centers in your brain, but you probably won't remember the drive, right? So things like that. That's why you kind of have that hazy memory in some cases where you kind of gloss over the details. You may try to fill it in yourself, but you don't remember a lot of that stuff. Okay, let's do a break. We'll come back in 10 minutes and start going over the limbic system. Okay, so we're about halfway through. Let's continue on with our talks of the limbic system. Any questions about memory? Or maybe you've already purged all of those memories. You had a brief seizure and you said, yep, already cleared myself of that. Ready for a new hour. Okay. So anyway, so driving systems in the brain, what kind of leads us to be awake and active? Some of this may be more or less activated right now. Hopefully some caffeine is helping out with some of that. But what you find is that a lot of wakefulness, a lot of excitation ends up developing from the brainstem. And so what you can actually see is if you were to, cut off the brainstem from the rest of the brain, they end up developing just, kind of unarousable coma, essentially, right? So when I say coma, what do I mean? They're non-responsive. You can't really wake them up. It's really the difference between, being just sleepy and being comatose is whether or not you can actually respond to stimuli. But essentially, what they find is that without that brainstem activation, or say if even you had increased pressure, say something like a pineal tumor that was actually preventing that kind of outflow of information from the brainstem, that stimulatory signals, it would kind of cause the same thing. Basically, be comatose until they can get some of that the outflow back again. So basically, we'll see that the brainstem directly stimulates that background level of activity, and we'll also see that we'll get some release of some hormone-like neurotransmitters that help with this as well. And then we can also see the brainstem helps with eventually going to sleep, hopefully. We'll see there's another area, there's an inhibitory area that helps with that. So you can see here on this picture how we can see the excitatory areas of the brainstem. Use my pointer. See the excitatory areas. Here's the inhibitory area, and so this is going to be what we call the reticular substance of the pons and the mesencephalon, or otherwise we'll know it as the bulboreticular facilitary area, right? So if you hear like the reticular substance or reticular area, that's usually what we're talking about, as it being this kind of stimulatory area. It's receiving a lot of sensory inputs, and so we already talked about this in previous sections, but it also is going to be important for sending out these excitatory signals through the thalamus. Right, sometimes it'll synapse with some nerves here in the thalamus, and then this will kind of spread throughout the cortex in order to cause wakefulness, essentially. And so it's a very important component of this, and you need to have that, otherwise you'll be comatose, essentially. And so we'll also find that bulboreticular areas we talked about previously being really important for helping with like anti-gravity muscles and making sure our posture is good and we can stand up against the forces of gravity. So looking at the signals that pass through the thalamus, we'll see that there's some rapid action potentials that come through, and these are very short-lived. So this can kind of like, keep someone awake for a short period of time if this was the only signal. But note that these are going to be releasing acetylcholine, right? And so if you think about it, like if you look at some like first generation antihistamines, so think about like diphenhydramine or Benadryl, one of the side effects you see is you take Benadryl, what happens? You get sleepy, right? So you get sleepy, and if you think about it, like that drug also has some anticholinergic activity. And so one of the things you can think about is antagonizing effects of acetylcholine and actually leading to some depression of that kind of excitatory effect. So you can kind of think about it like that. But this is very short-lived. More often than not, they're going to have these kind of slowly conducting neurons. They synapse onto the thalamus, and then that synapse will go and lead out to the cortex. And this is going to be a lot better for kind of long-term excitability. So this will be the thing that keeps you up for, say, hours versus just a few seconds to minutes. So basically that excitatory area gets determined by the number and type of sensory signals that are coming into it. Certain things are going to have stronger signals than others to kind of wake you up and jolt you into activity. Pain is going to be one of the big ones. So patients who have chronic pain issues, guess what they probably also have problems with? Getting sleep. Yeah, absolutely. So if they're having this kind of chronic pain signal coming in, like that's still activating the brain to stay awake, and so sleep problems can be a big thing. One of the other kind of comorbid conditions that can develop along with chronic pain states. And what we see, there's kind of a positive feedback loop from the cortex back to these excitatory areas during this kind of thought or motor process. So if you are all of a sudden, you're kind of daydreaming and you're kind of not really paying attention, and then you kind of start to get a little sleepy, say something happens where all of a sudden, so you're resting your hand on or face on your arm, and then all of a sudden you slip. Right, all of a sudden that sudden motor input or that sudden sensory input can jolt the person back awake because of that feedback from the cortex, leading onto that excitatory area that will then feed back through the thalamus back to the cortex. So it's kind of a positive feedback loop to make sure you stay awake. Thought processes can do this as well, especially if you're like sitting there and you're just kind of quietly asleep, and then you're like, oh crap, I got that test at 8:30, right? Hopefully you guys don't have that experience, but that can be one of those things that kind of stimulates you from the cortex back down to that bulboreticular area. And so on the inhibitory side, though, and this is probably helpful for getting patients to sleep, is going to be this inhibitory area that releases serotonin, or 5-HT. Do you guys remember what that 5-HT means? You can consolidate that memory, I can tell. 5-hydroxytryptamine is the name of that. So if I put this here so I can start kind of training you guys to recognize that, because this will come up a lot when we get to the psych section in Farm 2, I think. But basically, you'll have these kind of inhibitory neurons releasing serotonin. We call this the raphe nuclei, and so that's going to be feeding onto that excitatory area, and that will inhibit it. So you have less outflow coming from here, and thus you have basically depressed excitability. You're going to have more likely the patient to be depressed in a mental status state, and then eventually sleep, hopefully. That's what you're shooting for. So this picture really confused me for a long time. I'm like, that's a really funny looking brain, and then I finally realized it was actually a rat brain that they were looking at. So again, this is not human brain. This is just a rat brain. Hopefully your patient's brain doesn't look like this. Otherwise, unless you're a vet, maybe that's okay then. But you guys will be people providers, not animal providers. So looking at some of the other kind of neurohormonal activity, we can see that our catecholamines and this tryptamine here are going to be very important for helping to regulate wakefulness and sleepiness. So the norepinephrine pathway is going to be very important here. So we mentioned norepi. Remember the other kind of broad name we use for drugs or substances like norepi and epinephrine? So certainly is noradrenaline is one name for it. We're going to call these catecholamines. So if I say catecholamines, I'm referring back to epinephrine, norepinephrine, dopamine as well. So basically with our catecholamines, you have things like norepinephrine. This is being released from that locus ceruleus that ends up being located between the pons and the mesencephalon. I'll show you a picture of that in just a second. But you'll see that the nerves end up spreading throughout the entire brain, and this generally is going to excite the brain in a lot of cases. So you can see here in this rat brain how locus ceruleus is going to be releasing norepinephrine all throughout the cortex, even in the cerebellum, and that's going to generally be excitatory. It's generally going to wake the person up, essentially. You'll also find a little bit later that's involved in REM sleep. And again, REM sleep we'll find is not the very restful type of sleep, but certainly we can have still some brain activity going on. So we'll look at that later. What else is happening usually during REM sleep? Yes, when you're dreaming, right? So it makes sense because you're having some of the stimulatory activity. This is where a lot of dreaming actually occurs here as well. So it kind of makes sense, especially if you like eat some like weird food before you go to bed or something like that. Like it really kind of gets kicked into high gear. Anywho, then looking at dopamine, we know that gets released from the substantia nigra. Remember that was being important in the basal ganglia action, and so this is fed mainly into the caudate nucleus and into the putamen. So again, sticking with the basal ganglia, and in some cases it's thought mainly to be inhibitory, and other sites it might be excitatory. So just know it can kind of have a mixed action there between excitation and inhibition, but this is going to be more affecting things like motor control and whatnot, because again, basal ganglia are really important for developing those kind of more complicated motor patterns. And then here's again the human version of this. So you can see basically here's the locus ceruleus where epinephrine is going to be coming from. You can see here the substantia nigra, where the dopamine is going to be end up releasing. We'll talk about these gigantic cells, these gigantocellular neurons, where the acetylcholine is coming from, and then here's the raphe nuclei, where serotonin is being released. You'll notice serotonin is kind of having bidirectional transmission here. It's thought that serotonin release into the spinal cord is also helpful for inhibiting pain signals. So again, in general, that serotonin is going to be inhibitory, helps to kind of blunt those signals from coming in and maybe keeping you awake, right? So we'll find that the other projections are going to go into the diencephalon and some into the cortex, and in general it's going to be inhibitory and helps to promote sleep. Acetylcholine, on the other hand, is going to be released from the gigantocellular neurons. They're going to be excitatory, and again this will also be releasing acetylcholine back into the brainstem and the spinal cord to be excitatory, to wake the person up, get them moving. So looking more specifically at the limbic system, we'll see that the major portion of this is going to be the hypothalamus. But how big is the hypothalamus? Very tiny, less than 1% of your brain mass. It's like 4 grams or something on average. You can kind of see the hypothalamus just right here, right in this little section here. You can see how it's kind of how it's situated amongst the rest of the limbic system, essentially. And so basically there's lots of section here. We're going to talk about some of the specific actions of these in a little bit more detail in just a second. But we'll find that the limbic system is very important for what we call these kind of vegetative functions, chief of which is being behavioral control. But we also see control of things like body temperature, osmolality will be affected by this, urges to eat and drink. So lots of different things, especially subconscious things, you may not be kind of consciously controlling. You're going to be controlled here through the hypothalamus and the rest of the limbic system. So again, this is providing good two-way communication basically to all levels of the limbic system, and so you'll find that it will also send us back and down into, basically it's kind of 3 pathways that the hypothalamus is going to be communicating, one of which is going to be back and down into the brainstem, and you'll find this is mainly going to be synapsing into the reticular areas, also can be affecting the autonomic nervous system, as we'll see. Again, that makes sense based on what we'll learn in the next lecture, that when you're controlling things like body temperature, when you're controlling things like osmolality, how that's important to be affecting some of that. Looking at upward, and it will synapse higher into higher areas of the diencephalon and the cerebrum, so you can have some effects there. And then also, importantly, as we know from the pituitary functions, it's going to have this hypothalamic infundibulum that will control some of the release of both those kind of trophic hormones that we saw that release things like, corticotropin releasing hormone, or thyroid stimulating hormone, a thyroid hormone releasing hormone, I should say. TRH is what gets released from the hypothalamus. We'll look at that again in a second. But it helps to control those kind of pituitary functions. Okay. Again, less than 1% of brain mass, very small, but it is super, super important. And losing the hypothalamus can lead to some severe derangements in control of the body. So I'm not going to have you remember specifically which areas of the hypothalamus control all of these things. I don't know that a lot of people could tell you that. They're actually out there in clinical practice unless they dealt with this all the time. But know the functions of the hypothalamus and some of the things you're going to see being performed through its function. So first of which, looking at things like these vegetative and endocrine functions, one of the big ones being things like cardiovascular function. You can see that the hypothalamus is going to have good effects on both heart rate and blood pressure changes. Some areas will actually be stimulatory and will help to raise blood pressure and heart rate, especially if it's detecting that cardiac output is not high enough or certain areas are not being perfused well enough. And you can also find some inhibitory areas. So you can actually see that the heart rate and blood pressure will drop in those cases. Temperature regulation is going to be managed through here as well. These preoptic areas respond to the blood traveling through it based on the temperature. If it's too low, then what might you stimulate in order to raise your temperature back up? Muscle contractions, right? And what is that normally typified by? Shiver, yeah, so you shiver, right? So that's actually one of the things that we find kind of problematic. So one of the things we do for patients who have a cardiac arrest, basically you go down, you've got a cardiac arrest, we want to cool the patient down, right? Because usually by cooling the patient down, metabolism goes down, right? And we want to try to preserve that tissue as best we can, So you'll find that therapeutic hypothermia. One of the things you have to combat is the shivering that occurs, because the body wants to respond to that. It wants to maintain homeostasis, and it says, hey, I don't like being 96, 97 degrees or whatever. I actually don't remember what the temperature is off the top of my head. Someone else could probably tell you that. But basically, do you know? Because you're shaking your head.
I just remember seeing it.
Yeah, I remember seeing it. So basically, we're cooling them down. The body's response is to try to shiver, and so we can do things like give them paralytics to actually prevent that from occurring, right? There's some other drugs we can use as well, but that's one of the things that the hypothalamus is helping to manage. Again, if you're too hot, what could you do to respond to that? Yeah, so a lot of it is going to be based on things like sweating, so that way you can have that evaporative type of cooling. You also see a lot of like cutaneous vasodilation, so you're getting more of that hot blood up to the skin where it can be transferred out through the skin and through the sweat, right? So all those kind of things can happen to help regulate body temperature. You'll see a lot of body water regulation happens here, so like the thirst sensation that gets stimulated by having the osmolality being too high or too low. Yeah, too high, remember? So when the blood volume gets low and you start to concentrate a lot of those electrolytes and things like that, you're going to cause the osmolarity to go up, and that's going to stimulate that thirst response. And then also you're going to have things like ADH being released from that supraoptic nuclei that will help to try to hold on to more water in the kidneys and also be kind of vasoconstrictive and all those kind of actions. So a lot of this is starting to kind of come back around, so hopefully you can recall all those things we talked about, right? I hope. Hopefully. It's all in there in your kind of intermediate memory. You just have to codify it and go back and kind of pull it out of the memory bins. Not the trash bin, the memory bins, right? Also, other things, we can see oxytocin being produced in the hypothalamus and then getting eventually secreted out from that posterior pituitary, but this is where oxytocin is going to be made here, so that helps obviously with uterine contractions, helps with ejection of milk from the breast tissue, things like that. You'll also find some GI and feeding regulations. So there's this lateral hypothalamic area that actually stimulates hunger, so that will cause the animal. And actually, if you were to see like damage to this, where it's kind of having overactivity, you can find that animals will continue to eat even though they have certainly enough food on board. And they can develop like really kind of extreme obesity. And versus on the other side, you have this ventromedial nuclei. You have a satiety center, and satiety is basically what? Yeah, I'm full. And so, for instance, if you had too much activity there, even though you may still be very hungry, or you may actually need food, you can find the animals that have this overstimulated may actually just waste away because they will not go after food, because the power of the hypothalamus is such that it will just shut down that urge to go and get food ever, right? So satiety center, unfortunately this is not being activated quite enough in me. I'm going to try to work on that eventually, but and we'll also see that it has a lot of control of that anterior pituitary. So by releasing those kind of not pro hormones I should say, but those hormones like the corticotropin releasing hormone or thyroid releasing hormone, things like that will help to stimulate that anterior pituitary to release a lot of those different hormones for further endocrine function, right? So you guys remember all those we covered probably back in section 1, I think. So if I say like things like prolactin, what does that do? The milk production, right? So if I were to say something like thyrotropin releasing hormone, what would that do? Makes TSH, right? And that would cause the thyroid hormone to start to develop more thyroid hormone, T3 and T4 and all that. So again, it's all back there. You guys will recall it, I'm sure, as you start to review it again. Anywho, but so we see a lot of endocrine control. The other thing we're going to see in the limbic system is going to be control of behavior as well. So some of the things you can see by stimulating the hypothalamus. If you were to stimulate, say, the lateral hypothalamus, and I term this the hangry center, so if you guys want to use this forever and credit to my name, that would be great. Basically what you end up seeing is increased thirst and hunger. You see increased level of activity, and then in overstimulation you can see overt rage and fighting that can develop from this, right? So it's called the hangry center. just a brief kind of funny story. When me and my wife first started dating, I informed her that, hey, if I'm really in a bad mood, chances are I'm either I'm usually just hungry, right? So I get pretty hangry. So just be aware of that. And so we were like visiting my parents' house or something, and I was trying to put together this fan, this like big wrought iron fan, very, very heavy. And so she'd accidentally dropped the base of it like directly onto my toes, and I'm near lopped off my big toe. Anyway, so I'm standing there and just like looking very angry and in a lot of pain. And she's like, oh my gosh, do you need a sandwich? Are you hungry right now? How do you get you a sandwich? I said, yes, but my toe also really hurts. But so anyway, so I said, clarified, I could either be hungry or I'm also in a lot of pain right now, or you need to drop something on my foot. So it's basically the only thing you need to know about me, and then, then we're golden. So anyway, some other things that happen here in the hypothalamus. So like the ventromedial nucleus, this helps to stimulate that satiety I mentioned before. It decreases eating. Also will kind of instill this feeling of tranquility in the patient. So that can be one thing you see there. You can also find this periventricular nuclei, this thin zone here, is going to be responsible for the fear and kind of punishment reactions that we'll talk about in more detail in just a little bit here. And then certain areas are also going to be affecting sexual drive. So if you were to cut this out, you would eventually see like no sexual drive in the patient or the animal, whatever you're having to look at. Reward and punishment center. Yes, ma'am. I'm not gonna ask you that specifically, but I may say like which one of these is the hypothalamic function. If you stimulated. Trying to think about any other questions. You'll see in the review kind of what questions will be on the test. I actually still need to write the test, or at least review it. So I'm not going to be that granular about it. I'm not going to say, well, activation of the lateral nuclei does this, because I don't know that from memory. I'd have to read up on it every time I look at it. So, all right. So anyway, reward and punishment, also the name of my new mixtape. Just kidding. So this is also known as satisfaction and aversion centers. Basically, this is kind of the things that we remember, right? So you remember things that make you feel good, and you remember things that make you feel really bad. The reward centers, you'll find that the kind of major centers end up getting found in things like the medial forebrain bundle, lateral and ventromedial nuclei, the hypothalamus. And what's interesting with the really potent reward centers, if you overstimulate them, the patient actually gets so happy they get super angry. I guess, I don't know. But basically what you end up seeing is you can have overt rage can happen here, right? I accidentally mistyped that, but I should say actually stimulates overt rage that occurs. I'll fix that before I upload the video. But you also have some kind of less potent reward centers. And find that this is in the septum, the amygdala, the thalamus, basal ganglia. These will all also stimulate kind of reward, in those pathways. So they were actually in the book, they were talking about these experiments they were doing with monkeys, where basically they had electrodes that were set to stimulate specifically these reward pathways, and there'd be a little switch, and they could hit the switch and they get a nice reward pathway activation. And so they would find that they would just hit it hundreds, thousands of times in a row to get that same reward kind of thing. They'd give them really good food, they wouldn't eat it. They'd just keep slapping the button, right, to the point that they'd probably die off from starvation. Very, very potent stimuli for, storing memories, for doing those actions again. Very, very important feature. And then we also have the punishment centers, and so stimulation of these ends up causing things like displeasure, fear, terror, pain, sensation of that kind of punishment effect. And so basically the most potent centers you're going to find here are going to be around this gray area. This surrounds this aqueductus sylvius and the mesencephalon, and then also into some of the other paraventricular zones of like the hypothalamus and the thalamus. And apparently my typing was getting very bad last night, so just be aware of that. Anyway, there's going to be some less potent centers as well that you're going to find in the amygdala and the hippocampus. And basic excitation actually will inhibit the reward pathway pretty significantly. So basically, you'll find that the stick takes precedence over the carrot essentially. So if you were to have, say, stimulation of both of these, the punishment centers tend to override that. So you tend to have a bigger association with things that are punishing or things that are painful than things that are happy, right? So I'm sure you guys all remember that really embarrassing thing you did a few years ago, right? I remember that in a lot of detail. I have those memories all the time. Yeah. I tried to repress those memories. I don't know what you're talking about. So you remember bad memories more so than those kind of happy memories because of that feature there. So looking at the rage pattern, so basically if you see strong stimulation of these kind of punishment centers, and at least this is what happens in animals, you're going to find they immediately start to develop this kind of defensive posture. They start to growl. They start to bring their claws out. They're getting ready to fight in a lot of cases. It's very kind of like sympathomimetic kind of looking picture, right, or activating that sympathetic nervous system. And so normally you're going to find this gets held in check by certain inhibitory centers, especially in the hypothalamus. And so when you have that occur, basically you're trying to keep that kind of rage in check. And some patients you may find that does not always happen. Sometimes they may have inactive inhibitory centers or maybe an overactive fear center. And then of course, you know, because when you think about it, like when you get scared or you get hurt, like, you know, you get defensive. And so that's kind of a natural pathway for that. Now, on the other hand, if you have stimulation of the reward centers, you should see kind of placidity, tameness, kind of a calm, just kind of tranquil kind of person. So, and then, of course, with memory, sensations that stimulate reward or punishment pathways tend to be reinforced, whereas you know, situations where you don't really have either of those being activated. So, as I mentioned, like, you know, driving in this morning, like if nothing really eventful happened, you're probably not going to remember that, and you habituate those memories and those pathways. Versus if you got into a car wreck this morning, you'd probably remember that for a good long time, right? Because those kind of memories that affect that punishment center are going to be remembered more likely to be remembered. Okay, so any questions on that? Okay, so moving on to states of brain activity. Yeah, hopefully you're having some brain activity. See a few people, maybe not so much. That's okay. We'll wake you back up. Basically, when you have someone who's unconscious or asleep, it should be this unconsciousness from which a person is going to be aroused by sensory or some other type of stimuli. So if I shake a person and they're able to wake up, they were just sleeping, right? Versus if I shake them and I, you know, pinch their nipples and I sternal rub them and all this kind of stuff, that's comatose, so they don't wake up to that, right? You laugh, but that's something that we do in some patients to see if they'll actually wake up. You know, sternal rub's actually pretty painful, but sometimes you'll give them a little purple nurple and see if they wake up. But there's two main types of sleep you're gonna deal with. That's the clinical term. So use that on rotations. You'll look like a rock star. Anyway, two main types of sleep. There's going to be the rapid eye movement, or REM sleep, and so this is basically find that, and then you have the slow wave sleep, which they call non-REM sleeps. That's what, if you ever see a term that's what that's referring to. Basically, you're going to find that about 25% of your sleep is going to be more dedicated to the REM cycles. This is going to be occurring about every 90 minutes or so as you're asleep. So you can kind of see these this graph here. It kind of shows you that initially when you're awake, especially if you've been awake for, say, you know, 16 hours or so, you're going to basically just fall directly into kind of a deep sleep, right? So you don't necessarily hit REM sleep, or if you do, it's very short during that kind of first cycle. But then every 90 minutes or so, you should pop back up into REM for a short period of time, and it can depend on several factors like how long this is going to be. Usually 5 to 30 minutes or so, and you especially see that as you become more well rested, that REM sleep tends to get longer as you go on. So initially, very early on, when your body needs that rest, the REM cycles are pretty short, versus as you get closer and closer to waking up and you're well rested, they tend to get longer. And so that also makes sense, because usually when you wake up, you're just having a dream, right? That's the same thing that's happening right there, right? So you usually wake up from a dream, you're like, oh man, I want to get back to that, and then you usually pretty quickly forget it. But so anyway, typically you find that REM sleep is not very restful, and this is when you're going to have the most vivid dreaming that occurs at this stage here. And then with the slow wave sleep, the non-REM sleep, this is going to be strong, low-frequency waves. We'll look at brain waves in just a few minutes here. But they're going to be very restful sleep, usually during that first hour. So again, usually you bypass the first REM cycle in that first go around. And so you can kind of see, we'll look at the waves and kind of what these mean in a little bit. But you can see basically when you get to kind of more and more deep stages of sleep, you start to kind of progress through these less and less frequent waves that occur. And so you kind of get down to the most infrequent ones, which would be these delta waves, which we'll go into detail on those just a little bit. So again, REM sleep is going to be associated with dreams. Also, you have those kind of active body movements. So you ever like feel like you're like drifting off to sleep, and then all of a sudden you start to have those those jerks, right? So sometimes that can be associated with those as well. Called those myoclonic jerks that can occur. It's kind of irregular muscle movement that happens there. So you ever like feel like you're falling, all of a sudden you kind of jerk yourself awake. But that's kind of what we're kind of referring to, those myoclonic jerks. But anyway, they can be more difficult to arouse these patients, even though they tend to be, the brain is more active during these phases. It's more difficult to arouse that person, even though they tend to spontaneously arouse during a REM cycle in the morning, right? So you just happen to wake yourself up in a lot of cases with that REM sleep. Normally, you're going to find that muscle tone tends to be depressed, usually through inhibition of kind of spinal control areas. And so again, if you think back to when we were talking about serotonin coming from the raphe nuclei, that made sense, because that was still going down into the spinal cord. You can see some inhibition coming about from that, right? Typically, you see the heart rate and respiratory rate tend to be somewhat irregular, so kind of fluctuate a little bit. And then again, I mentioned those irregular muscle movements. So brain tends to be highly active during this stage. You can actually see as much as a 20% increase in metabolism. So we kind of call this paradoxical sleep, because you think you go to sleep to rest, but this REM period is not really very restful whatsoever, right? On the flip side of that, you're going to have slow wave sleep, which is going to be very deep and restful. Typically, you're going to find a depression of blood pressure, respiratory rate, heart rate, and basically the basal metabolic rate should be decreased as well. So again, this is where you get most of your rest from as you're sleeping. So some of the theories of sleep, this is also another thing where we don't quite know all the details on it. So similar to memory, you know, there's lots of theories out there for what is the initiator of sleep and why sleep works the way it does, or even what the actual purpose of sleep is. Also, then obviously we just need rest in a lot of cases. But for instance, like, you know, we're giving medications. We don't have like a really good specific medication to help you sleep. We basically just give you something that helps GABA work really well and just kind of snow the whole system. We're just like, well, we don't know what to do with this. Let's just inhibit everything and knock the person out. So this is why the medications we have for sleep usually are not super great. You know, they usually have a lot of side effects associated with them. A lot of people who take medications to sleep, they usually wake up very groggy because they're having some residual effects from that. So again, sleep is not something we have a full understanding of just yet. But what a lot of people think is that serotonin coming from that raphe nuclei are going to be majorly inhibitory. They're going to affect that bulboreticular system and also be affecting the spinal cord as well. So that's what's thought to kind of help with sleep. Interestingly enough, we also have these orexin neurons, and these release orexin, and another name for it is hypocretin. So if you ever hear that, it's something that doesn't get a lot of attention in sleep studies, but it is very important because it gets produced by the hypothalamus and actually produces excitatory effects on these orexin receptors. So certain neurons will express this. What's interesting is that when you have a loss of those neurons, you end up having a lot, or causes this condition called narcolepsy. You guys know what that is? Basically, like, you just fall asleep right where you're standing, whatever you're doing. You might be driving, you might be doing something really important, it can be middle of surgery, hopefully not, but you just basically just fall asleep, right? And so some of it is thought to be due to a lack of this orexin coming from there. Also, they can have what you call cataplexy, and so this can occur basically have just total loss of muscle control. It's kind of like a short form of paralysis. And some patients with like narcolepsy, there's some interesting videos if you look up cataplexy where sometimes like strong emotions can even bring this about. So someone will be sitting there, they hear a joke, they laugh really hard, and they just fall out. Right, they're on the floor, basically unconscious for a short period of time. So it's very kind of interesting, but obviously very debilitating to the patient, especially if it's not very well controlled. So we have certain drugs that can try to affect this, but that's one kind of aberration you can see. So again, we still don't know a lot about this, but you might find more details as we kind of go further into the future. Now, looking at sleep waves, again, I thought this was a very cute picture of a baby who's having, what do you call this? EEG, electroencephalogram. So basically, we're trying to measure the electric potentials that are being traveling through the brain, through the scalp. So that's what we're trying to be measuring there. So again, EEG, this is going to measure those potentials through the scalp. We're going to see marked changes in the type of brainwave activity that we're going to see during wakefulness, during sleep, even during seizures. It can all look very, very different from one another. And so what you find is that most of the time, brainwave functions tend to be pretty irregular and they do not have a specific pattern. So if I'm thinking about something very actively, I'm having lots of different parts of the brain kind of all working, you know, doing different things at the same time. And what you find is that there's not a lot of kind of synchronized firing of the neurons, right? So because everything is kind of working in different directions, everything is either being inhibited or excited, there's no real pattern to it. And so what you find is it's pretty low voltage at that point because a lot of these action potentials cancel one another out. So we'll talk about some of the activity you can see between something like alpha and beta waves, but typically if like I'm actively thinking about something, these beta waves are going to kind of take over, right? So there's not really a whole lot of pattern to them. As you start to have more synchronized firing of the action potentials together, as you start to get more and more of them firing at the same time, you get to see more of this kind of high voltage, you get to see a better kind of synchronicity there, and that's where you can start to see things like the theta waves, where you start to notice a little bit more of kind of a sine wave type pattern, and certainly in the delta waves, which we're going to see a lot in deep restful sleep. You notice here that you're going to have basically big firings of neurons all together, because again, there's not a lot of brain activity going on. Okay, so most of the time you're going to be seeing, especially if the person's like kind of actively thinking about something, they should be having a lot of these beta waves. If they're kind of just sitting there quietly and not really doing a whole lot, alpha waves will end up being more prominent. We'll look at those in just a second. But basically, we're looking at that synchrony of action potentials, you know, because it takes thousands or millions of them to be able to fire at the same time to be read across the scalp, right? So that electric potential has to go through the skull, through the skin, the hair, to be picked up by those electrodes. And so you need a lot of neurons firing all together in order to be able to detect that. And so as you find mental activity decreases, that synchronicity tends to kind of sync up more, and so you're going to find that when you have decreased mental activity, you're going to find that the neurons start to fire more in synchronicity. They're going to have higher voltage because they're kind of all firing together at the same time. Versus when you're having active mental thought, which hopefully most of you guys are having right now, you should see that voltage is going to go down as the neurons start to cancel one another out. Does that make sense? Okay. So you can see here where you have something like surgical anesthesia, where we're basically having a very depressed level of consciousness. A lot of the neurons are firing synchronously, but they're not firing very often. Versus as you get kind of more and more brain activity going on. So for instance, if I was having active attention to something, you'd see that the voltage goes down, but there's also less synchrony there, but there's more activity happening at the same time, which is why it kind of looks less and less basically it just doesn't look like any kind of pattern whatsoever, versus having something like a full like tonic-clonic seizure, as we'll talk about seizures in just a second here, where basically everything's kind of firing all at the same time in a very unsynchronized kind of fashion. So anyway, so looking at the alpha waves, these are typically going to occur maybe like 8 to 13 cycles per second. Normally, if you're just kind of sitting there, you're quiet, and you're not really being very contemplative, you're going to find that you'll have these kind of alpha waves. These tend to disappear during sleep, especially as the brain activity starts to go down during those deep kind of restful periods. And what you find is that when the patient turns their attention to something, they start thinking about something, it tends to be replaced by these beta waves. Beta waves tend to be a lot more frequent, so again 14 to 18 cycles per second, and then you'll see that you can kind of vacillate between beta and alpha waves as you are putting your attention to something. So in this case, you can see here how you have the sequence of alpha waves that are occurring. Patient opens their eyes, so they're actively taking in the scene, looking at the lights, looking at what's going on. You see beta wave activity. Notice how it's a lower voltage, even though it's kind of more you see more firing, you see more activity going on, but it's at a lower voltage because a lot of those neurons are canceling each other out. They're not really firing synchronously. Versus when they close their eyes again, not really putting their mind to anything, you'll have a replacement of the alpha waves. Okay. So theta waves tend to show up either during certain degenerative brain disorders. You might see this during certain emotional states. Certainly you start to see theta waves pop up as you are going into deeper states of sleep. And this happens to be much more slow, so about 4 to 7 cycles per second. And then finally you have the very slowest waves, the delta waves. These tend to have higher voltage because, again, it's very slow frequency, but you're going to have higher voltage because a lot of those neurons are firing together. And about less than 3.5 cycles per second, much greater voltages. You find this either in deep sleep, sometimes in infancy, and then also with serious organic brain disease. So again, if you put a gun to my head, I could not interpret an EEG for you unless maybe they're seizing. You can probably tell that pretty easily. But as one of the things, especially if you're working with neurologists, you're going to learn to look for patterns for things. Especially with different areas of the brain, you can see like where certain maybe a tumor might be present, causing certain effects to occur, or maybe they've had a stroke and that's affecting certain areas of the brain, which is making it more or less likely to fire. Right. So these are kind of things you'll end up looking for when you're looking at an EEG. And so very frequently we end up looking at patients. You guys ever heard of like a sleep lab before? Yeah, so very frequently we'll use one of the functions of a sleep lab, in addition to looking for things like sleep apnea, we can also use it for nighttime EEG monitoring. So especially for seizure patients, we can kind of monitor them from the time they're awake, the time they go to bed, to kind of see where the changes are, and if you happen to catch a seizure, that can be very useful as well to see kind of what's going on. You can look for things like focal points for seizures, which we'll talk about in a second. But those are all things you can do, especially kind of an overnight stay when the patient's sleeping. One of the ways that we'll use this for some of our patients, trying to think. Yeah, so for some of our tox patients, seizures can be a very common thing that can, a very common occurrence that can happen with drug overdose. And so one of the things we can actually look for is using an EEG, because some patients will have what we call a non-convulsive status. Because when you think about someone seizing, what do they look like? What do you think of? Shaking, they're moving all over, they're probably not conscious at the time. You're probably thinking about like a grand mal seizure, right? So that's kind of the most common one, the tonic-clonic kind of seizures, which we'll go into more detail in a second. But sometimes patients can have what we call a non-convulsive status epilepticus. And basically, status epilepticus is just kind of a prolonged seizure where basically the patient does not really ever get back to their baseline state. But actually, I should probably get into this detail. I'll talk about that in a second. But basically, seizures are going to be this disruption of brain activity. Basically, you have an uncontrolled excessive neuronal activity. And there's lots of reasons for this to occur. Certainly electrolyte disorders, certainly hypoglycemia can cause this. That's actually one of the first things. If you have a patient who has a seizure and you don't know they have a seizure history, you always check a glucose, right? Anytime you have a patient with altered mental status, check a glucose. Good practice for all of you guys who work in emergency medicine. But certain toxins, stroke, trauma, all of these things could potentially cause a seizure based on abnormal firing of action potentials within the CNS. So looking at something like a focal seizure, these are typically ones that are going to be starting in a small localized region, and they may start to spread, or they may not spread depending on the type of seizure disorder the patient has. They typically have these kind of localized reverberating circuits, and you remember when we were talking about action potentials in the CNS, there's that absolute refractory period, right, where nothing can trigger an action potential, and then you have the relative refractory period, where a strong signal could reactivate that action potential. And so that's kind of what's happening here, is you have this kind of reverberant kind of signal kind of traveling all throughout here, kind of reactivating a lot of these action potentials. So it's not organized. There's no actual conscious thought going on in those areas. It's just reverberating around, right? And so you can have a simple partial seizure, which basically the patient doesn't really have a noticeable change in consciousness, or you can have a more complex partial where consciousness is impaired. Usually it'll be unconscious in a lot of cases. And so also what you can find with these, they can be preceded by an aura. And anyone know what an aura is? Yeah, so you see this a lot with patients with migraines as well. I don't cover migraines in this section, but we'll talk about that in pharm. But certainly you can have auras there. You can have auras for seizures as well. And usually it's either some sort of like emotional, some sort of sensory change that occurs in the patient. So they know that, hey, when this happens, when I start to see, like, get really sensitive to light, or if I start to feel really sad, or if I start to have something that's not normal, that they can usually detect that, hey, this is an aura, I'm probably about to have a seizure, right? Which can be useful if the patient can kind of predict that sort of thing and not be in a state where they need to be at full control of whatever they're doing. But you can also have like abnormal tics. Sometimes you can have like, smacking of the lips or sticking the tongue out or things like that can also be associated with these auras as well. And so basically what you see is that the time after a seizure, once they kind of recover from that, there's going to be a period of time where they're really not with it. You're going to see they're really kind of just still out of it, and we call that the post-ictal period. Right, and so you need to give them time to kind of get back down to their baseline, their baseline mental status essentially, right? So it can be that post-ictal period. So basically what you can find with certain patients, we have a condition called status epilepticus, where basically patients have multiple seizures or a very long-acting seizure where they actually will have a seizure, go in its post-ictal period, and then go back into a seizure. And so because they never have a return to baseline, we call that status epilepticus. So if you ever hear that term, that's kind of what we're referring to. But as I was mentioning, for some patients, you may not see any of those kind of convulsive effects, so especially if you ever paralyze a patient. So oftentimes when a patient's seizing, one of the things you worry about is their airway, right? Because again, they're usually not having very controlled respiration, and so they stop breathing for themselves, and that is usually what ends up leading to further seizures and acidosis and eventual death. So one of the things you do when you intubate a person is give them a paralytic. So at that point, you can't see if they're seizing anymore, especially that tonic-clonic seizure. So that's where we can use EEG. Sometimes in the ER or in the ICU, we will use it to look for things like non-convulsive status epilepticus. So it's kind of just one thing that you might see. But other than that, you may see some focal seizures will start at a particular point, and then they become secondarily generalized. Generalized means basically you're having kind of the whole brain being affected by these seizures and these abnormal electrical impulses. You can see here how this might start, this portion of the cortex, travel to the thalamus, and then would travel out from there. And of course, you could just have generalized seizures in the first place. You can see here this is primary generalized, where it can start from the thalamus and spreads out immediately at that point. So, even with generalized seizures, they're diffuse, they're pretty excessive and uncontrolled neuronal discharges, and as I mentioned, that focal seizures can become generalized secondarily. And typically what you can see with this is either a generalized tonic-clonic seizure. This is formerly known as a grand mal seizure, if you ever heard of that. And basically the patient loses consciousness. They're going to kind of alternate between this kind of tonic and spasmodic kind of muscle contractions. That's where you can see kind of the movement around. And then airway compromise is the biggest thing. So they may kind of this term like swallow their tongue or something like that. But basically they're unable to coordinate breathing, and that's usually what ends up leading to patient demise eventually. And so patient may also become incontinent. That's one of the things of someone wets themselves or have defecation, something like that. That is a common occurrence with these kind of generalized seizures. You can also have what we call petit mal or absence seizures, not absent seizers, absence because you want to sound nice and fancy because it's French. But basically, this can involve a lot of the thalamocortical brain activating system, as we kind of talked about earlier in this section. And usually it's about 3 to 30 seconds or so of unconsciousness, but with this, you don't really see the tonic-clonic kind of effects. Basically, the person will just kind of, they'll be talking to you, all of a sudden they go out, and they come back. All right, so oftentimes they may not even have a break in their speech pattern if it's a short enough time frame. So you may see some twitching in the muscles, but usually it's just kind of that kind of blank stare. I see a lot of petit mal seizures happen in this class pretty frequently. So you guys should probably get that checked out, just FYI. So anyway, so that's it for the CNS section. Do you guys have any questions? Okay, let's do a 10-minute break. We'll come back and then talk about the autonomic nervous system.